Hello everyone, good afternoon. My name is Gil-Salmerón and I'm a researcher at the International Foundation for Integrated Care, who is really happy to welcome you here in Belfast at our 24th conference in this really close to our heart session regarding homelessness. And we would like to thank to the project Conferernce, who is supporting with co-funding the space and the session to have this grateful discussion with all of you and with our incredible panelists. So thank you very much, and I will start presenting some of the data that was behind the project and the idea that we had, and is that the number of people in Europe experiencing homelessness understood as lack of housing, unstable housing is increasing. The numbers are shocking, and one of the most prevalent problems and leading cause of death is cancer. So one of the factors that is influencing this is the limited access to healthcare and how fragmented it is for them to navigate, and also prevalent cancer risk factors. But when they found all the barriers in accessing cancer prevention initiatives is where the problem gets worse. So we conducted some interviews and we extracted that tailored cancer prevention initiatives were needed. And here is where the Conferernce project became a reality, thank you to the funding of the European Commission. We are a consortium composed by partners such as the University of Valencia or NGOs working in the field that are providing a lot of experience and delivering the service. I would like to play the video, please. The link is... No. So now I would like to show you a little animation that we created in the framework of the project, just to provide you more detail, a framework of what the project scope is and what we are developing. Okay, no worries. So the idea was that cancer prevention and screening services started sending a letter home, and most of the screening programs started like that. So when we saw the call of the European Horizon 2020 program, we thought that this created a barrier and also one of the most problems. And we started thinking about potential solutions in this case of exclusion. So we saw that in North America, they were proving the patient navigation model that was a support for people experiencing homelessness, but it was not actually something that was structured or put in function, just in studies. So we saw the opportunity to bring that kind of innovation to Europe, and we are using the European funding to co-design, first of all, test and extract conclusions for the future. And now the video.
Cancer is one of the leading causes of death in Europe. Reports note that cancer-related mortality is twice as high for people experiencing homelessness. At least 895,000 people face homelessness in Europe on any given night. They encounter significant barriers when trying to access often highly fragmented healthcare systems. These may be related to discrimination and stigmatization, a lack of access to information, or the need to prioritize finding accommodation. The reasons for high levels of cancer-related mortality with people experiencing homelessness are often linked to unsafe health behaviors and harsh living conditions, as a result of marginalization and social exclusion. Conference's vision is to prevent cancer and allow for early diagnoses among people experiencing homelessness. by delivering person-centered interventions to overcome health inequalities and facilitating timely access to quality cancer prevention and screening services. Truly contributing to leaving no one behind in the fight against cancer in Europe. The Cancerless project aims to deliver an innovative solution as an aggregate intervention, based on the combination of the tested patient navigator model and patient empowerment model, to create the Health Navigator model for Europe. This evidence-based patient-centered intervention develops patient empowerment. It does this through health promotion, social support, and education, all aimed at increasing timely access to primary and secondary prevention service. Cancerless is conducting pilots in Madrid, Attica, Vienna and Cambridge in the United Kingdom in order to test the Health Navigator model. Each pilot focuses on supporting the needs of the people experiencing homelessness. Whether that involves cancer screening, promoting a healthier lifestyle, or providing support with cancer treatment. This support is provided with the help of the patient navigator that operates in each pilot. With the use of the Health Navigator model, Cancerless aims to prevent cancer, allowing for early diagnoses among people facing homelessness by delivering person-centered interventions to overcome health inequalities in Europe. Follow us on social media and visit cancerless.eu to learn more.
So that's the main scope of the project, what we are doing, but this is based in some of the previous work that we have been conducting. First of all, we conducted a literature review to study what patient navigation strategies have been used with this population. We have conducted also interviews and focus groups to see what were the barriers when accessing to this kind of services. And then we did co-design focus groups to see what were the potential features of the model to be implemented. And we extracted the commonalities in the 4 countries to see how the model could be more appropriate and feasible to other European countries. So now we are testing what we call the Health Navigator model. As in the video was said, we are working with patient empowerment and patient navigation, just combining them in the Health Navigator services through the participatory design. And we are providing services as promote cancer awareness and self-management. We are also conducting an individualized assessment to identify health needs and barriers. We are coordinating access to care for them. And we are also providing practical assistance when it comes to make the appointments, helping them with transportation, and supporting them through the consultation if they don't understand something. The study has been, is finished, but we are now finishing the conclusions of the statistical analysis. We are really happy about the initial results and how promising they are, not just about the quantitative, but also about the qualitative. The people who has been participating and who has been included in the study, they see a lot of value and a lot of promising value of the model and the intervention. And now we are jumping into what we call the standards for integrated cancer care for people experiencing homelessness. We have developed a literature review on the different aspects of the care continuum of cancer to see what we could identify as a standard or care delivery principle to maintain what would be a care pathway for them. We see that opportunistic testing in first points of contact is really important, tailored screening programs for the population, community-based preventive health programs, culturally and trauma-sensitive population-specific patient navigators, care community networks, interdisciplinary collaboration and support meetings, dedicated linkage to care coordinators, integrated healthcare services were also really important in the literature, embedding primary care physicians and also incorporating palliative care specialists and multifaceted consultation services. And what we are now is identifying the whole care pathway dedicated to people experiencing homelessness through cancer. And what we are, this could be like how it looks. And what we are trying to do is to picture the standards here and see how this could be integrated for them, and scaling up them into local plans for the future. So public administrations and NGOs, because they are mostly who works with them, can apply them in their services and be evidence-based in their service delivery. So we are currently redefining those standards within a Delphi study. So if you want to participate, we are now accepting participants, as we have launched the first round of the Delphi. And yep, that's all. Thank you very much. And that's all from my side. As chair, I follow. And now we are going to give the floor to our second speaker. So Lisa Good from the Institute for Health Research, the Notre Dame University of Australia. And here you go.
Thank you. Good afternoon. I acknowledge my co-presenters back in sunny Perth, Amanda Stafford from Royal Perth Hospital Homeless Team and Andrew Davies from Homeless Healthcare, and I'll explain what they do and why I'm speaking about my work with them in a minute. So firstly, as is practice in our country, I want to acknowledge the traditional custodians of the land on which I work and live, which is the Wadjuk people of the Noongar Nation. And this acknowledgement of country and the Indigenous people of Australia is particularly salient when we talk about homelessness. So in Australia, about 3% of our population identifies as Aboriginal or Torres Strait Islander. About 1/3 of our homeless population identifies as Aboriginal or Torres Strait Islander. It's part of Australia's shame. So as one of the early speakers in this session, just to reiterate that homelessness is a health issue. I don't think anyone at this conference has to be convinced of that, but when I first started working in this space 7 or 8 years ago, I had a couple of grant applications knocked back and literally was told homelessness is not a health issue, it's a social problem. But no matter what measure of health and health equity you look at, this is a group that's left behind. So whether it's comorbidity, multimorbidity, premature mortality, chronic disease, cancer prevention and early intervention, as we've seen. And so the reality is we end up with poor barriers to primary care engagement and much higher use of acute hospital use once things are already well advanced. It's well recognised around the world that life expectancy is a measure of not only individual health and well-being, but countries like to boast about their life expectancy as an economic metric and a political scoring point. And so it's deeply distressing to me in our research that's been tracking homeless deaths in Perth for the last 6 years to know that the average age of death is only 48 years. So it's a life expectancy of more than 3 decades. I know from literature and other organisations around the world that sadly Western Australia is not an anomaly there, and the average life expectancy pretty much in the countries that are doing this kind of work sits at a 3-decade gap. We've had a lot of attention in Australia on closing the life expectancy gap for Aboriginal people, and that is starting to shrink. And for homeless people, it's much, much worse. So why is that? Well, I would argue that this is a group that's been failed by the mainstream health system because you can't actually separate out the things that I've got up there. And I guess this is the, we often talk about silos, but I guess I wanted to try and approach it a different way. And these are things that I think aren't really picked up on in our health system very well. I've intentionally put trauma and pervasive trauma up in the top left-hand corner because for many, many people who are homeless, that underpins it all. I know there's cost of living crises around the world and a housing crisis, and so we are seeing in Australia some people newer to homelessness that maybe previously haven't experienced that, but the vast majority of people who are homeless in our country have had enormous adverse childhood experiences, trauma in childhood, compounded by trauma in adulthood, and then the trauma of trying to stay safe on the streets. And so that trauma impacts on everything. It impacts on the way they are prone to distrust people. It impacts on perceptions of being stigmatised and the reality of being stigmatised, of feeling not understood. And our health system is not very good, despite the rhetoric, about being trauma-informed. And you only have to think about the bright lights and noise of an ED department if you have a mental health condition, high anxiety, and are used to being stared at and judged or ignored on the street. We also hear a lot in our research that it's the struggles of day-to-day survival. So health is just not a priority. It's not that they don't care, it's just that you're trying to find a safe place to sleep, a meal, not get your belongings stolen, or sadly in our country, getting moved on by police or shop owners. And we had one person that we were doing a case study on. He'd been moved on by police 450 times. Where was he meant to move on to? And fundamentally, housing is health. And so Michael Marmot, who we all love at a conference like this, said it really well a number of years ago when he talked about the futility of discharging people back to the streets and the very conditions that made them sick in the first place. In our research, we're really big on the lived experience accounts and the human face of the numbers that we also do. So I've got a two-part case study. The second part's not going to be so gloomy. But this is one of the early ones I did when we were trying to advocate for funding for more joined-up services and to fight a service that was about to be discontinued funding. So Chris, not his real name, late 50s when he first came in contact with a homeless team at the hospital, 26 years of rough sleeping. Often living under a bridge, multiple health conditions as you can see there, mental health and physical. In just a 2-year period, he had 69 ED presentations, almost 90 inpatient days, which was a cost to our healthcare system of $302,000 at that time point. And most sadly of all, at his last ED presentation before he got support, it was written on the summary that he didn't have an acute issue. He was given a taxi voucher and discharged back to the bridge. I'd like to say that this is in the past, it doesn't happen anymore, but I just was given an example last week of someone with cancer discharged to sleep in his car because he had nowhere to live. So what have we been doing to change this? Trying to get a bit more upbeat now. So the four key players in the story I'm telling today is Homeless Healthcare, a specialist primary care service that goes to where people are. Sees about 3,000 people a year. It's integrated with a homeless team embedded in a city hospital. So nurses and GPs from Homeless Healthcare go into the hospital. There's also a caseworker and a clinical lead in the hospital doing kind of work outside of it. Lots of links with the homeless sector. So this is a health organisation and the players. So you've got nurses sitting in meetings with homeless organisations, links to community legal services and so on. And then since about 2017, when I offered some free research services and haven't looked back to Homeless Healthcare, really working with them to do what I call real-world research. So a lot of it is evaluating of their services, of trying to find the spin to put on it to convince government to not defund something, to continue funding or to let them trial new services, and to be an advocate and for me to be able to stand up and say things to the media or in Parliament that it's difficult to say if you're funded by government. And the diagram on the right-hand side is acknowledged to Shannon on my team, who's my diagram whiz. So really trying to picture the fact that we, for all of these services, the person is at the centre, the purple circles are the different settings that Homeless Healthcare works in, and the connection outside, and then obviously underneath all that sits the social determinants of health. I've already heard at this conference talk about continuity of care and the importance of that and the importance in trust building, and it was in a session that I was at just a little while ago, and I think it's challenging for any organisation to have that continuity of the same people, but Homeless Healthcare works really hard at that. So it's intentional that you see a couple of the staff in these slides are the same people. So it's the nurse doing street outreach that will also see people in the clinic. It's the peer worker at the medical respite centre that will also go out onto street outreach. It's the GP that will go into the hospital and then can see someone in the community. It's hard to achieve that, and particularly with staffing changes, but it's really important because this is a group that needs to feel safe in who they're seeing. So coming back to Chris, the good news part is that he was engaged and there was trust built with the homeless team at the hospital. They advocated to prevent further discharges to street. I feel that they possibly shamed some people that had given him the taxi voucher on his previous ED admission. They worked with Chris to identify what his housing and social needs were. So he was in his 50s, and in Australia you don't qualify for aged care accommodation until you're 60, although we've argued that that should be younger for people who are homeless. But so there was a lot of advocacy to get him to an aged care hostel because of his premature ageing exacerbated by 26 years homeless. Once in the hostel, his health stabilised, continued to see a GP, and we looked up his hospital use data just recently, confirmed that he was alive, which is no mean feat when you remember how young I said people die, and he's only had one ED presentation in 6 years. I wanted to reiterate again, housing is health, and I guess at the most fundamental level, I've got a quote up there on the right-hand side, I won't read it, but a gentleman I was talking to who just nailed it himself and said that, you know, because of not having his house, his foot went gangrene, he had diabetes, they chopped off one toe, he was still homeless, and so the next toe went. And he offered to show me, and it was pretty manky. But the numbers I've put on there is just from some recent research we've done for the homeless team, and a little brag moment for our team. The report that we produced led to the department giving the team another 5 years funding. So I think that it's really hard for not-for-profit organisations and services to have the money for evaluation. So I would encourage you to try and find a friendly academic partner who might be able to work with you to achieve that, because it can get results. And what we did here, Matt, my statsy nerd colleague, said, Lisa, why don't we look at what difference does it make whether people were discharged? They might have all got support from the homeless team, but what difference does it make if you discharge them back to the street, which sometimes is unavoidable, or to accommodation? And you can see there in those arrows that it's the people that went to some type of accommodation where you see the most significant results. And so now we're lobbying with our hospital system to give them some brokerage money to be even able to get people into short-term accommodation. It's not perfect, it's not permanent housing, it's certainly not housing first, but it's better than a discharge to the street. Because what we see in all of our research is that the longer people are homeless, the more their health deteriorates and their hope deteriorates, and we see this escalation of their hospital use. And it's no wonder to me that some of the international literature talks about deaths of despair. Just before I conclude, I wanted to give you an example of our latest Joined Up Health and Social Care in Action, which is literally co-located in a single setting. So North America has led the way on having respite care for people who are in hospital and homeless. They're well enough to be discharged in theory, but they've got nowhere to go. So this is Australia's first fully medical respite centre. There's some non-medical ones, but this one has 24/7 medical care, nurses on site, GPs coming in. It's got caseworkers, it's got peer workers, the first peer workers dedicated to homelessness in our state. It was opened by the government 2.5 years ago, and based on the evaluation we did after 1 year, they increased it. So, you know, there's a bit of pressure on us to pull out some great results for the second year. But you can see there in that model of care diagram that it very much is multidisciplinary, continuity of care, and I wanted to emphasise the low threshold nature of it. So many of our homeless services, the accommodation ones, you know, you can't be intoxicated, you can't be using substances, you can't have a weapon in your backpack, and so on. And I understand all of that, but this tries to be really low threshold. And so people, there are rules. You can't use on site. If you bring in a knife to keep yourself safe in the street, it goes into a locker. But they really recognise the pragmatics of being homeless. And there's a quote there just from one of the residents. So to conclude, what all of our research and work in this space has shown is that when you do integrate health and social care, it is greater than the sum of its separate parts. I think what we've been trying to demonstrate throughout is that there's tangible individual benefits, and we never want to lose sight of that impact on the person, service impacts and health system benefits. And I've had to get really savvy at knowing what is the current jargon for health systems, so that will vary, but at the moment bed flow is the big thing in Australia, bed blocking, you know, being able to discharge more quickly, so we whack that into our reports. And I think something that we don't talk about enough, but I observe so much when I talk to people themselves, is the power of hope. And I don't know how we even frame that to a commissioning service to say that you want to provide a service that gives people hope. But you can see in this quote here from someone who'd been homeless for 18 years, ping-ponging around social welfare, homeless, justice system, not getting the help he needed. Because you give up in life sometimes. You give up and you think people don't notice you or don't care. I want to thank you from the bottom of my heart that I'm able to have all these things offered to me, because I thought my time was done years ago. I didn't have any hope, but this MRC, this is the one that gave me hope. Thank you.
So thank you very much. And now we give the floor to our next presenter, Maxine.
Hi, folks.
Thank you.
I'm just going to tell you now I've left my phone over there and I don't have a watch on. So I'm going to ask my lovely colleagues in the middle to wave at me if I talk too long. And if I say something that doesn't make any sense to you, or I'm using an acronym and you'd like to know what I mean, just wave and I'll try and answer. So my name's Maxine Radcliffe. I've got various letters after my name, but I am a nurse and a manager currently working in Ireland's health service, where I'm also undertaking a PhD. And I'm lucky enough to manage a fabulous inclusion health team, some of whom are sitting in the middle there, so they do all the real work. But this is a brief presentation about a systematic review I'm doing at the moment as part of my PhD, which is looking at women's experiences of homelessness in high-income countries. So it's going to be pretty brief. I'm going to talk a little bit about homelessness and what we know about women. Why am I doing a systematic review and a metasynthesis? Show you my lovely Prisma diagram. Might even explain it. And some of the preliminary findings. So, homelessness in women. This is going to be really shocking to everyone in the room, but it's a really gendered experience, homelessness, and defining homelessness is quite difficult because the traditional ways that homelessness is defined, it's about measuring people. Are you bedded down in that doorway? Do you count? So I would have been involved in street counts, and I'm going to walk around and it's going to break the sound. But I would have been involved in street counts in London and a little bit in Dublin and in other places. And usually the statutory way of measuring it is you're visibly homeless. We can see you bedded down with a sleeping bag, and I am an official person who's allowed to count you. Okay? So women in general don't like, it's not safe for them to bed down on the streets in a sleeping bag. So they are counted less. So notionally, there are less homeless women. So it's a bit of a circular challenge. The other thing is the way that homelessness is defined. So it's a bit of a funny concept because it is about something you don't have. You don't have a home. But then what does home mean? Is a home a place? Is it a roof and four walls and a door? Or is it a feeling of safety and of community? And it means a lot of different things to a lot of in different cultures. Certainly, I know the more I get into this research, I feel the less I can give you a neat little answer on what it means. But in statutory terms, it's just about the roof. So in terms of statistics, less women. I think in the last rough sleeper count in Dublin, it said there were 83 rough sleepers, if we're just talking about homelessness in terms of rough sleepers. And I think about 20 of those were women, if that. Don't remember the exact stats, terribly sorry. Common effects of homelessness on women are, and this is, from the review, but all of this would be anecdotally known anyway to people working in this service. Exposure to further violence and assault, separation and isolation. So again, it's that feeling of safety and of comfort and your family and your community around you that you become distanced from. Othering, judgment, stigma, and shame. So I imagine people are familiar with the concept of othering, but it is where when you other someone, you are distancing them, you're able to talk about them as a non-person or as they're just a migrant, they're just a homeless person, they're just a woman. It's probably not the greatest explanation you've ever had, but I'm sure you get the idea. So why do this? Why look at this? Because it's all obvious, isn't it? You know, isn't this obvious? Well, actually, so as someone who's been involved in commissioning homeless services, trying to decide what money to spend, there isn't a great amount of clear-cut evidence. There's the measurement problem I've talked about, and women's voices in the traditional literature. So most of the research that's looked at what's known about experience has gone and talked to people in homeless services. So they're already in the homeless service. They had to get in there, and the vast majority, to do that, they had to prove they were homeless, and lots of them are men. So your archetype of a homeless person is a young single man in the literature. So not a lot is known. So I wanted to look at this because, and I probably should have said this at the beginning, my background, I ran a women's homeless clinic in London that was just an open access for 5 years. And we're in the process of trying to set up a very similar thing in Dublin at the moment. So really would like a nice, neat evidence base to be able to justify what we're doing, as if we didn't have one already. So metasynthesis, wanted to look at what's out there. I thought as a practitioner coming to it that I knew what was out there. It's been quite interesting to do the metasynthesis. And for people who might not know what a metasynthesis is, it's kind of a way of meshing it all together. So we look at all the literature and then we aggregate it and try and make sense of it. And I chose to do something called a meta-ethnography, which is a way of systematic reviewing that allows you to develop lines of argument or new theory based on what the papers that are in it. So I love these diagrams, not? So this is my Prisma flowchart, which I can read it down there just about. So we did a big search, did 6 different databases, ended up with about 2,846 abstracts, cleaned them all up, and at the end, we've ended up with 33 papers talking about 32 studies. Now, I will say this is slightly old because when you embark on these things, I don't know if anybody in this room has ever done a systematic review or a meta-ethnography, but you have this great idea about how long it's going to take and how quickly you're going to be able to do it, and then it takes longer. So we had to redo the search in December of this year, and basically it's added about 3 papers. So there is an updated Prisma, but it's not in here yet. So anyway, we end up with our 33 papers. So what do they tell us? And the evidence is broadly situated in, I would imagine, the places you kind of see represented up here, actually. So we've got the US, the UK, Canada, Australia. You've got a typo in there in Australia. There's 1 study from Ireland, which is where I'm currently working, and Israel and Poland. And that's it. There's not a huge amount of other literature out there. The overarching interrelated themes that we've arrived at, and we're in the process of finalising a socio-ecological model of women's experiences of homelessness, are around precarity, risk, and identity. So I'm going to try and explain what precarity is. It's a concept from social geography, and it's about the destruction of the conditions of livability. Okay, so when I'm talking about 0 hours contracts, the idea that you don't know where your next meal, your next paycheck is coming from, or how much it's going to be. It's living at the gift of somebody else, and it's actually a Roman concept. So this was one of the key themes that we found. We looked at, in these 33 studies, we looked at both what the women themselves said in the quotes and what the authors found, and precarity would be one of the big overarching themes. As part of that, there's this idea of the deficit lens. So women are very often looked at in terms of what they don't have. So you don't have a house, you don't have your children, you have a problem with this. There's a very negative framing of the way homeless people in general are described in the literature, and this is magnified again for women. Another theme that women talked about a huge amount was their loss of agency, and I'm going to read this quote here. This is a 78-year-old woman I think she was in Canada or Chicago. I'm getting more used to the idea that my life is a complete waste. I do not have a family. I do not have a career. I'm not a productive human being. It's day after day of wasting my time. I am a walking, dying woman. I walk until I can't walk anymore, and then I sit. The buses pass me by. We are untouchables, and I do not think anybody's going to do anything about it. So that was a woman who'd been homeless for a number of years, and that, the sentiments that are in there are echoed through all of the literature of the 868 women that are in the final sample in the meta-ethnography. There's this idea of surveillance as well, where, even when you are in a hostel or you have access to somewhere, you have to abide by certain rules. You have to fit into the structure and you have to meet those things. And so you might go here for a shower, but then you've got to walk all the way over the city to get a meal, and then you've got to come back again, and you've got a 15-minute window. So there's a whole lot of the business of homelessness, and it being a almost like a full-time employment, just, meeting your daily needs for food, let alone any other aspect. There's another quote in here, and just someone talking about being a mother. My son is 6 years old, and this is the 6th apartment we will have to leave at the end of the month. I can't breathe when I think of the future. We are always living out of cartons. That example of we're always living out of boxes, we have to move all the time, that's very real. In the Republic of Ireland, we have, some of you may know, some of you may not know, a huge homelessness crisis. And I'm here speaking as both someone who experienced homelessness in my early childhood, but also as someone who's worked in the UK and a little bit in the US. And I will say, I have found working in the Republic harder by far than anywhere else, simply because there is no housing. So if you go on to DAFT, which is the national accommodation kind of website where you can buy houses and look at houses for rent, there's maybe 60, 80 houses. I don't know what the number is today. I should have looked it up before now, but like last week it was 83 in the country, the whole country. So it's, even if you are a middle-income professional with 2 incomes and 1 child, you're going to find it hard to find anywhere to live. We have a staff team working in migrant and homeless help. It's pretty big now, there's over 40 people in it. And I have a significant proportion of those staff are living in homeless accommodation because they cannot be housed in the Dublin region. So that's the scale of this in the locality where I'm working. So precarity is a huge overarching theme. Moving happily on. The other theme is risk. So as a woman, you are far more likely to have experienced violence that made you homeless, experience violence while you're homeless. I'm using violence here as a proxy for sexual assault, for all manner of things. I have never met a woman in my homeless clinic in London who didn't, and I did that for 5 years. I saw thousands of women who hadn't at some point been sexually assaulted. It's a routine experience. Women talk about it happening repeatedly to them. Again, this idea of exclusion and being othered and not good enough, looked down upon because you're a failed parent, you're a failed mother, how have you become homeless? That's all part of also the next theme, parenting whilst homeless. So I'll just read a couple of these quotes because I think it's important to give the women the voice in the room. I just came to shelter and my abuser found me, and childcare was walking back to the shelter with them, my children. And he jumped out of the van at the childcare people and started ordering my kids in the van, and they were crying and running in different directions. So anybody who's worked in a women's homeless service has probably experienced this phenomena of usually men outside being quite abusive, and that's a very common theme that they would have to deal with. So you're running a gauntlet the whole time. I went into the hostel. It wasn't actually too bad, and it was all right. And I met somebody, and I fell into a relationship with him. I fell pregnant with him, and I lost the child because he literally beat us up so badly that I lost the baby. So it's just been so many bad things. And that woman then went on to a cycle of losing her accommodation because she was no longer pregnant and all sorts of things. So I've been given a 2-minute warning. So my third theme is identity, with sub-themes of shame and stigma. And as I was saying, women are, to generalize about them, but you're othered, you're looked at as if, you're something on someone's shoe. This is an example from an ED. Drugs are the only thing that's ever been there for me, and nurses and doctors treat me like garbage. They think I'm in here because I want to get free drugs. Where is my selfhood? Where's my motherhood? Where's my privacy? Where's my tranquility? Where's my marital relationship? Where's mine? Where? There's no mine here. It isn't mine. So women become completely dislocated and they end up in a cycle of homelessness. Obviously, I'm generalizing here, and this is not true for all women. But so finally, we're pulling all of those themes together in a nice little model that I'll be able to show you next time in a lovely diagram. And we're implementing those findings in clinical practice in Dublin. And that's me.
So thank you very much. And now we have 2 presenters. I don't know who is first?
Nick's going to start us.
Okay. So I leave you with this pair. Sure.
Nick's just going to bring something up on his computer. I'll introduce myself first. So my name is Matthew Meyer. Lisa kind of rung a chord with me. When you offer as an academic to support this kind of work, there's no out, and that's okay. I really enjoy it. So I work at London Health Sciences Centre in London, Canada, and I'm also an assistant professor in epidemiology and biostatistics. And then my fantastic colleague here is going to take it over. Pardon?
Hi friends, how are you? I'm Mick. I'm with St. Leonard's Community Services, London and Region. Don't confuse it with London, England. It's London, Ontario in Canada. Much smaller, but we're not very ingenious with naming things apparently. So it's a running joke that I'm with the Ministry of Magic. That should probably be one of my associations. And Matthew is for today a muggle. Just like our colleague from Australia, it's really, really important to acknowledge the land that we in London, Ontario do our work on. And so out of deep respect for Indigenous peoples of Canada, we recognize that our work takes place on traditional Indigenous territories across our region and geography. The sacred land on which we live, learn, grow, and work together has been a site of human activity for thousands of years. And Indigenous peoples have been stewards of these lands, sharing the natural resources and harvesting only that which was needed for their sustenance. We acknowledge that the lands we call home are the traditional lands and waters of the Anishinaabe, Atewandaron, Haudenosaunee, and the Lenape peoples. Today, London, Ontario is still home to many Indigenous peoples from across Turtle Island, and we are grateful to have the opportunity to work in the community on this territory. There are long-standing relationships with the 3 local First Nation groups of this land. These communities include Chippewa of the Thames First Nation, Oneida Nation of the Thames, and Munsee Delaware Nation. We are committed to working toward reconciliation and to supporting the recommendations of Canada's Truth and Reconciliation Commission. This will involve listening to, learning from, and working in partnership with First Nations, Inuit, and Métis people. We are fully committed to taking action to ensure that Indigenous peoples feel welcomed, respected, and enabled to thrive within and through our work. Thank you. Before I begin, London, Ontario, just like so many communities around the globe, has experienced a prolonged, sustained, and very tragic crisis involving health and homelessness. In July of 2022, our community experienced just another preventable death of a beloved community member. That resulted in a hunger strike by community members in front of City Hall, and the result of it was a summit process taking place in November to January 2023. This summit, and I'll show you a photo in a second, brought together, and it was dubbed the Whole of Community's Response to Health and Homelessness. It brought together the whole of community. 400 people gathered over those 3 summit days between November and January to figure out a path forward. You see here a sort of a timeline of how the whole system development happened with different stages, including an implementation process, which we'll talk about in a second as well. So this is what the summit looked like, pretty much like today's conference or this week's conference. So again, over 400 people from the community attended, and that included folks with lived and living experience, folks working in social services, so working directly with homeless populations, folks in healthcare. We have 2 huge hospitals in our community who were present, folks from our big university and colleges, as well as developers, for example, property developers, who all came together because we saw there's a great need to work as a community together to solve this health and homeless crisis. We developed shared values and principles that every organization, every developer, every party present signed on to. I will not read them out to you, but it's a very holistic approach to solving or ending homelessness, because we can't just throw money at it, we need to end it for good. We also came up with a focus. We're comfortable with good enough to start, but we will evolve together. We knew that this crisis is not going to be solved or ended within a year, not even within 3 years. And we knew that we were going to make mistakes, and mistakes we have made. But we wanted to start with good enough for now and evolve together. This is sort of the conceptual framework that we developed around a network of hubs with multiple referral doors, where folks can call one number and effectively get somebody who's sleeping rough or is experiencing unsheltered homelessness can call and be referred to what we call hubs. Again, lots of purpose-built common core functions, and then a timely and direct pathway to housing, what we call highly supportive housing, but which we won't talk about today, maybe a little bit. We have incredible partners in health and homelessness and through the summit. So again, we had leaders, frontline staff from sector organizations, sector partners, hospital, higher education, any not-for-profit organization in our community came together, folks from mental health, women's safety, addiction services, harm reduction specialists, and we had the backing of our municipal government, so our city. There was also the development of a strategy and accountability table, again, leaders, EDs, CEOs from sectors, as well as, again, higher up city representatives. And we came up with a series of reference tables. They include the business reference table, but also really importantly, the funder-partner reference table, which includes, we have sort of 3 tiers of government: municipal, provincial, and federal, who sit at those tables, any big fundraising organizations, etc. And we also have an indigenous community reference table. So really trying to wrap around all of our community members and get the buy-in from all of our community members. Part of that table, or that system, is the System Foundations table, which Matt and I actually co-chair, with the mandate to recommend, co-design the policy processes and administrative components of the system response to best enable effective, coordinated, and accountable work by system response members. And our recommendations are to include outcome measures, reporting, and the development and refinement of policies and procedures. For today, we'll focus on the evaluation and research piece. because it's so important to do evaluation and research very, very intentional. We also came up with a set of values that was endorsed by the table first, then by our strategy and accountability table, as well as by our city council. So everyone, again, is on the same page here. And now we're coming to the outcome measurement framework.
Thanks, so that's where I step in. So I think it's important for everyone to acknowledge, and certainly was an important part of our journey, is the fact that many of our organizations, I think this was mentioned earlier, many of our organizations either do not have any resource to do any evaluation or research, or have one person who tries to do that off the side of their desk, usually on a Sunday afternoon. However, one of the things in this that we really tried to emphasize is that if this is truly going to be a whole of community system response, it needs to be a whole of community research and evaluation response as well. We all need to come together. We're very fortunate in London, Ontario, so the University of Western Ontario is there, Fanshawe College is there, London Health Sciences, a major academic institution, St. Joseph's Healthcare, on and on. We have major organizations that do have lots of money and lots of people with expertise in evaluation and research. So what we tried to accomplish with the System Foundations table and our partners is to get everyone kind of coming together and acknowledging that individually, no one can take on this full evaluation. Collectively, we can do it. But we have to do it in a coordinated and streamlined way. So as Mick said, we spent the first part of our work, a good 4 to 5 sessions coming together and talking about values and ensuring that we were all committed to the same values of research, including making sure that we weren't overburdening participants, making sure we were only collecting information that we knew was going to have action, but making sure that we were really listening to our partners through every process. So when we tried to take that work and then sort of solidify it, I'm a big fan of a good framework, like most researchers are, but I also acknowledge we have a lot of framework fatigue. So the last thing we need is another one. So we committed as a group, let's draw on some very commonly used frameworks and let's knit that together so we're all on the same page about our strategy. So the 4 that we adopted as a group are one that's commonly used in the business space, now, next, later. The concept here essentially is we know that there are things we need to measure now. We know that we're going to have to measure over and over. We're going to have to reiterate and kind of evaluate. But we also know that this strategy is not something that's going to take place over a 12-month or a 2-year or even a 5-year process. It's going to be a long-term sort of strategy. So let's think to the long term. Let's think about what we're trying to achieve, and let's make sure we're making a meaningful measurement on our journey there. So that's a big part of what we'll show you and what we've embedded here. Then this, for me, is, I don't know how many people here are familiar with Donna Bedian's triad, something I found in my graduate school and I absolutely love. I see a hand up, that's fantastic. Fantastic framework that forces us to think about structures being your nouns. Do we have people, places, and things to provide care and services? Processes, how do we use that together to make sure that we're effectively supporting people? And outcomes, what are we trying to achieve? So I'll come back to that in a second, because this hopefully will make sense as you see how we've pulled this together. The third framework, though, that we've adopted that relates to the outcomes is when we talk about outcomes, we want to adopt what's often referred to as a quintuple aim. In our region, we've adopted the terminology of the health equity-driven quadruple aim. That is your IHI triple aim that includes population health outcomes, population experiences, and total cost of care, or a value for the dollar that you're spending. The quadruple part, that, as many of you will know, that was added is provider experiences, so making sure we're acknowledging that the people who provide services matter. And then the 5th piece of this is health equity, and why we've adopted health equity-driven quadruple aim is you have to apply that to all areas of the evaluation. That's not something that stands on its own. Health equity has to be embedded in everything you do. And the last piece that we looked at was really a strong commitment to the fact that we have to use a mixed methods approach here. This can't be just about numbers, because that will never capture the full story of what we're trying to look at and review. So we have to adopt both quantitative and qualitative measures. So what we've done is essentially put all of that together, and we're asking our teams with areas of expertise, certain areas of expertise, to start thinking about how will we think about the structures, processes, and outcomes we need to achieve now using a mixed methods approach. And then we're going to ask them how would we repeat that next, so in the near future and then in the far future. And how we're going about bringing this together is when you start to pull this information together, this framework, the approaches together, what spun out of that, and this is the magic of what we're proposing, is really we need 4 teams of people with expertise. So these are researchers, these are evaluators, these are people with lived experience and frontline providers coming together to think about how are we going to answer the key questions that we have to have answered as it relates to the experiences and outcomes of the populations we're supporting, the experiences and outcomes of our direct service workers, the people who are providing the care. For those of you who know Donna Bedian's triad and appreciate it, this team 3 here, let's not forget, how do we measure whether or not we have enough things? Do we have enough houses? Do we have enough support and outreach workers? Do we have enough equipment and gear? We've adopted the terminology in some of the encampment work through our process, not to talk about handing out water or food, but to start to turn the terminology to basic human rights, basic human needs. So do we have enough of that to offer to people to support them? So we want to be making sure that we're thinking about that, but the cost of care piece is critically important here as well. So we want to make sure that we are thinking about, are we effectively using the dollars as a system to most effectively get the outcomes for the people we're trying to support. And then the last one that came up that we also, was part of what we're doing right here today, is acknowledging that we need people to do the research and evaluation of the entire process to tell the story of what we've gone through, and we have teams of people coming together to help us to do that. So we can share that knowledge with anyone who's interested. So that gives you a sense of our journey right now. We're still just in the early stages. The next steps for us, and this is really, really important, I want everyone to see this. This is not an academic exercise. Make sure that he reminds me of this anytime I forget. It's not about papers and publications. This is about generating meaningful information that's going to help us to make a difference and move this forward. So one of the ways that we're doing this is throughout our entire process, we've been capturing key questions from stakeholders, partners across the system. So this includes the people with lived experience of homelessness, the frontline workers for sure, city councillors, business owners, community members, everyone. We're trying to capture some of those key questions. What we're doing with those questions then is categorizing them into one of the 4 teams so we can bring the question to the team. And then on the teams, we're bringing together, as I said, researchers, evaluation experts, people with lived experience, frontline providers, to talk about what are the right data to use, what are the right methods to use, how are we going to together answer these key questions. And then we're going to bring that back to our key partners and do that over time. So we're starting to think about how we would use those methods year over year to check in to see how are we doing, how can we course correct, that kind of continuous learning cycle type of approach. We have our kickoff event next week, and we have over, I think it was 47 people already registered, researchers and evaluators registered to join into the cause. And we know there are more that we're going to tap on the shoulder to bring in. So that's the approach that we're taking. And as I said, what's going to be really important is that we make sure that this is continuous over time. Cheers. That's it. Thanks. Thank you.
Thank you very much. I'm sure that's not an academic work, but I'm sure that you are going to have really promising results that you can even publish and present in conference like this. Thank you very much. And now our last presenter is Kate, and I would like also invite Kate to invite all of you to the new special interest group of the International Foundation for Integrated Care. So first off.
Thank you very much, Alejandro. Good afternoon, everybody. My name is Kate Fraser, and I'm delighted to be here today. On a personal note, it's the first time I've ever presented at an international conference in Belfast, and being from Belfast, I'm actually wowed by what I am seeing, witnessing, and being part of, so it's fantastic. So do dare to dream is what I think, from as I've grown up and spent many years in a different space. So today I'm here going to talk to you about a small pilot study that I was involved in with colleagues from Dundalk Simon. And I'm here presenting, and my colleague Chris will be joining me at a moment you'll see on a slide as well. So I'm very grateful that he's come along. So I'm from University College Dublin. I'm an associate professor there. My background is in nursing and in public health and epidemiology. So this this study was funded through seed funding from University College Dublin, which was a small funding scheme under patient and public involvement. And that very much speaks to the national funding arm of the Health Research Board in Ireland, which has developed a PPI Ignite programme, which is very much embedding the lived experience and actually harnessing that in partnership for research. I'm part of a study team, and my colleagues on the study team are Una, Chris, Andrew, Nancy, and Tilo. So the background to the study, and I'm just going to very briefly kind of run through this and give you a background, a little bit of what we plan to do, and then what really this presentation about is talking about the PPI process and actually what that looked like and what we learned. So housing, as we know in this audience, and we're very much aware of, is a human right. The data on homelessness underestimates the extent of how big the problem is. Depending on how you're defining homelessness is, and we've heard how the definitions change, we could say the US, the EU, somewhere in and around circa 4%, but really and truly, can anybody put their hand on their heart here in the room and tell us how many people they know are homeless in Ireland with any degree of certainty? So the detrimental impact of homelessness is very much on health and well-being, as we know. It's not solely about a house, and we've heard this from the other presenters here this afternoon. And the impact on what it does to people, the reduced life expectancy and the higher incidence of morbidity. And as we've heard also as well, the definition in Ireland is back to 1988 legislation. And the narrow lens of that and the language used in it is very gendered from a male perspective. And we heard Maxine talking about women. So in Ireland, we have circa, again, I could say, somewhere in and around 13,500, 14,000 people on official statistics who will be in emergency accommodation. Of them, we have 2,000 families, and from that, we have around 4,000 children. So if we were only using the 1988 definition, those other subgroups and population groups wouldn't exist on that. So while homelessness services in Ireland are publicly funded, the services are often delivered by the charitable, non-governmental organisations. And there's a lack of available housing continues, as we know it's very much increasing. But little is known about the impact of living in a particular mode of temporary accommodation on the ability to exit homelessness or to live independently. So the aim of this study, as I say, it's a patient and public involvement-led study, is co-designed in partnership with a homeless charity. And the aim was to establish the feasibility of one type of accommodation and its impact on the lives of previous residents, and actually to learn from key stakeholders as well. Now, there's nothing that I'm going to tell you here that might not be familiar to all of you. And I think it just sets the scene of how important where we live means to actually our health and well-being. So the model of housing that we looked at from this small evaluation was a single housing unit that held for 4 single adults. Within it, there is 24-hour surveillance in common access areas only. People have their own bedroom, or they share a kitchen. They have their own room, and they've a shared kitchen. And they are, a member of staff is on the premises, kind of Monday to Friday, 9 to 5, and they are supported engagement for further education, for activities as well, and for activities of living. So what we did, so starting off in actually winning this funding, there was established a peer working group, and that was in October 2022. And the charity, Dundalk Simon, they established a steering committee in April 2023. And I suppose to put in context, Dundalk Simon, they are located in County Louth. So it was the first time something was actually being funded, even with seed funding, outside of the Dublin region, which was really important to get this understanding. And for the international audience, for people here, the location of County Louth is just beyond the border of Northern Ireland. So again, it's just, high levels of unemployment, high levels of deprivation in those particular areas as well. We got ethics approval from Dublin Simon, and then followed from UCD, then from their human ethics low risk. We completed interviews with previous residents of the location and key stakeholders, and that amounted to 9 qualitative interviews, and they were held between October and December 2023. And then in February of this year, we convened and we co-developed a PPI-led workshop to consider how might we harness the strengths and abilities to create a home from beyond. 16 people attended that. Again, people who had been previous residents, peers within the service, people from the charitable organisation, and their key stakeholders in the county as well. So today's presentation, I'm just going to give you some preliminary findings from the interviews. We're still working on that analysis, but it was just to give you a brief snapshot of some of the interview data. To discuss then the PPI-led research from the perspectives of Dundalk Simon community and the shared learning from this experience, and again a takeaway message from the study. So what we learned, and I go just look at this preliminary analysis, some of the key kind of like codes and themes that have come up around a happy medium, personal strengths and building agency, a sense of independence, visible trust and organisational endorsement, and normalising life. It's a happy medium. Have support if I need it. The ethos of the place is that you're back to work and back into education. There's a lot of trial and error, but the proof is in the pudding, and CR allows us to see whether someone is able to master a larger degree of independence. It felt good. No one was watching you 24/7. It was back to freedom. I found who I am again. The status of having your own front door. What a door key represents. Connector and engagement, opportunity, and unlike previous experiences of the services, it's a very community-orientated, collaborative approach. It's a long-term support plan for moving on, to build skills needed to manage your life independently. Oh, definitely, it's a much more relaxed environment, and there's a lack of chaos. They gave me discipline to show me the right things to do, you know. There's no drama, no shouting, no screaming, no trouble, no drugs, no nothing. It's seen as a transitional space. What is that meaning of that physical space? The impact of the transition on self and feelings? And then what I leave behind, and the what next? And who is living with me? I had my own room. It's just like sharing a house. You know, it's just, I was a little bit more free. It was calmer, more free to come and go as you please. It's a lot quieter. It's just like a normal house, you know. You had your own room. Yeah, safer. I trusted the people. It was the best decision I've ever done, to be honest. It changed my mindset completely. Positivity, motivation pushed me forward, and I even started to believe in myself. We just made a bond, and you have to get a bond, really. So now I'm going to ask Chris to join me, and Chris is going to give his perspective as actually one of the people who helped design the study and from the provider's perspective. So you're very welcome, Chris. I'll let you introduce yourself. And what I say is, Chris is no professional speaker, and I'm delighted that he's come along. So, Chris, if you'd like to tell everybody who you are and where you come from.
Chris Duffy. I'm from Dundalk originally, and I've worked for Dundalk Simon Community for just short of 9 years now. And I spent the past 3 years in the service, well, here to speak about today.
Thank you. And why do you think, like, the idea for this study came from Dundalk Simon, it didn't come from UCD? Why were you interested to know more?
I suppose we had the space there in the house that we were using, but a common theme you would have had, when even I seen it myself working in the hostel, was a couple of months after a client would move on into independent living, we'd find him he's back in the hostel with us again because he struggled on his own without the 24/7 supports. So we wanted to set somewhere up to kind of give them a chance to develop the independent living skills they needed to support themselves when they moved on into their own home.
That's very good. And you were part of the team from the beginning, from that October, 2022. And I know it took a while to kind of get things going. So maybe if you can you talk to us about what did patient and public involvement mean? Do you know, when we said those things, this is a patient and public involvement study, you're part of it. What did that mean as opposed to different research or any other research you've been involved in?
When you said it to me first, I didn't have a clue what it meant, to be honest. but the UC team helped me through, I suppose, workshops, different training to get to know that what it was all about. And I felt it was a good research project for the service we were running, because it involved the clients a lot. It was the main part of it, I suppose.
That's very good, thank you. And I suppose Chris's role, and part of that was the recruitment, and actually even peers to come work with us. And actually part of it was actually looking at our topic guides and the questions, and actually what questions we could ask. Do you remember? We did that as well. And I suppose, you know, what I'd say is, why was it useful for Dundalk Simon? Even at this point, we haven't got final reports and things like this here, but even at this point, was there any benefit to Dundalk Simon in actually working in partnership for this?
Well, given that it was quite a unique service in our area, it was good to almost advertise the service that we had to, as we mentioned, the key stakeholders that were involved with us in funding it and stuff like that. So, again, it was good to get the clients involved. I think that was very important for the service we run.
That was very good. And, you know, Chris played a huge part in actually that recruitment, and it really came through because the accommodation that we had, I think you said that about 19 people had come through when we started the study. And all of you who work within homelessness services know how hard it is to connect with people when they have left a particular service. So out of those 19, you were able to engage with 9 people who had been there before, and from that 5 then actually wanted to actually show up and be part of the interviews. So that's quite a testament to actually, you know, you and actually that piece of kind of coming together. So that was really it. So are there any big takeaways for you, Chris? You know, that's what I said, you know, we're analysing data, but, you know, from you, is it different to other research studies that you've done before?
Well, it was first time doing a research study, I suppose, for me, but the big takeaway I took with it was of the previous clients coming back and the feedback we got from them. It was good to kind of know the service was working, and the job we were doing it right, and having a benefit in other people's lives as well. So the feedback I got from a former resident is probably the biggest takeaway I took anyway.
That's fantastic. And what about the workshop?
Yeah, I enjoyed that too.
That was it. And I suppose, as I say, I leave the final word with you, Chris. Is there anything that you would recommend as being part of a PPI or a co-design study for anybody in the room that's being asked to take part? Or, you know, we hear about this, the lived experience, you know, kind of like, what would you say?
I suppose that just get involved. It was an experience for me. Trust me, PPI were the 3 hated letters for a long time, but all the work we put into it was, I think, was very beneficial for myself and the service. And if anything, we've built a relationship now between Dundalk Simon and UCD for moving forward that we're better prepared if anything else ever comes up again for another one.
Yeah, thank you. And I think one of the things that came out actually in the workshop today for the special interest group, where we talked about that everybody wants a study done and the PPI is a piece that you do, but there isn't time to actually think what that looks like. And part of what this looked like was the funding stream for UCD was it had to be a new partner. It wasn't someone that you'd worked with before. So in fact, it was that idea for me that I said, if nothing ever happens on this study, the most important thing is we have built trust and we have a partnership, because actually you can do so much more. You go beyond, in fact, what your study is about. And from my perspective, and I hope that kind of that was something that we kind of really feel, and I suppose that was it, that trust of actually coming along today.
Yeah. No,
So that's really all. And I suppose really just in summing up, you know, the big ideas that we have is that strength of the approach, you know, the question and the undertaking of this evaluation of this model of a house and having your own front door key, and actually Dundalk Simon having the faith and the trust to actually want to develop that type of accommodation, and then to see how could it develop, what could be done differently. They came with that question to us, and that's where we've worked together with the funding that we have to bring this into realisation. And actually the clients who had lived in the house, they were the people that said initially to your colleague Trina from Dundalk Simon, we need to find out why this is working, you know, why do we like this, you know, that kind of way, and why were things that were coming together. So it's really what we define success is. It's not big numbers, we're not here with hundreds of people, but it's how you can impact on people's lives and even learn from the people who are managing the service and providing that service, but really actively listening to the people who are living there. And I think, as you said, what we hear is how it's made a difference to somebody's life. So thank you.
Thank you.
So thank you very much for the presenters for being on time. We have now some room for questions and answers. So is there, yeah. Hello?
We all know housing first is very important for homeless people. Like you said, home is the start of everything. Did one of you ever tried using house containers?
Say that again.
House containers as a house,
Housing
like we use for refugees and things like that.
So, just speaking as a clinician, we don't typically, in my experience, we don't typically decide where people get housed. I know it was a project in East London and they're talking about scaling it, and certainly in my current professional role, I'm here talking about my PhD, but we would have a lot of people being put into all sorts of modular units, but there's all kinds of issues associated with that. So,
Sorry. I was just going to comment from an Australian perspective. We also have a terrible housing crisis, and that pops up from time to time. And I believe there is, it's hard even for us to get the containers. They're often used by our mining sites. I think the really important thing is for anything like that is about how you still retain the dignity and the way it's set up. But I work with another organisation that's doing some, trying to really keep the price down, and prefabricated quick builds, which are small homes, but not as small as a container, and you can build in the windows. But yeah, I think we just have to have governments think more creatively, and it drives lots of people in my state to despair that they're not thinking outside the square in terms of what housing looks like, or housing first has to be rapid housing, and we have, our whole state has a commitment to housing first, but no one's getting housed rapidly. And so I think there are lots of people that I've spoken to on the street and in other unsafe situations that would say they would welcome a garage or a container or something. But then I think the challenge is, if we're providing it as services, not to ever be conveying, something is better than nothing, because I also feel, so I think it has to be done well.
Hi, thank you. We last winter, as part of our winter response to health and homelessness, and in order to get our 680 plus unsheltered folks out of 10 cities effectively, we had a small modular settlement where we, I think, housed 40 individuals with supports for the duration of December through April. But it was an interim solution, which obviously has its problems, because come spring, those folks were returned to unsheltered homelessness. And there were, to be frank, there were lots of problems with it, which is the reason why we didn't go down the same route again this winter.
More questions? No?
I can add to, if there's no questions, I can add to that response there, as I think it really is important. Part of the whole of community system response that we put together was a commitment, and I talked about Team 3, to acknowledging we have 600 plus people that we know are living rough in difficult circumstances. We need to build 600 appropriate, highly supportive housing units. So that's part of the set the target, work together to do it. The interim that Mick presented is the concept of a hub that's been co-designed with people with lived experience to say, how can we meet your immediate needs? And part of that is similar to what we've heard from others, and I think many in this room would understand. I need a place that where I can lock the door, I can keep my stuff safe, I can actually go to sleep, not worrying about somebody stealing my stuff or worse. So there's kind of that hub concept as we work on the innovative housing solutions. But I think what's been really inspiring, as I mentioned, we've got city councillors, we've got people working both provincially and federally to start to think about, so how are we going to do this? And recently, we're having developers step up, willing to contribute to getting some of those units built. We have health partners coming together to talk about how we would support them. And we're starting to see innovative solutions like office buildings that are now completely empty because everyone's working remotely anyway, being converted. So opportunities like that where I don't know that would have happened if we hadn't all come together. So we're really seeing some inspiring things coming out of this.
There are more questions.
Well, thank you for that. I just wondered, do you think that we need to do more with the public? When I work in a homeless practice, GP practice, and I think what I find is other people's lack of insight into how people end up homeless. And I'm sure that contributes to other people's trauma and how they feel about themselves. So I wondered what do you think about that, and how could we address that to improve and try and get rid of that stigma?
I'll just speak briefly. I mean, yeah, I hear that a lot, and I think that is a challenge. And certainly, when myself or colleagues are talking, that's why we always, try to have the human story, which some of my colleagues here have done as well, around because I think there is often that assumption that either the classic ones I hear is that some people choose to be homeless, they've got mental health issues, they've come out of jail and they kind of deserve it. The pejorative views of society are really terrible, and I'm talking about even amongst people that supposedly you would think would be more enlightened. And I find that people are really shocked, particularly, for example, around, say, the homeless women, when they, like in our country, the biggest driver of homelessness amongst women is family and domestic violence. And they either flee and end up homeless or don't flee and are at high risk, or murdered in our country, one a week. So I think that it is about how do we raise that. But then the challenge also with that is that then it seems like even the more people don't go, but now it's even more complicated, Lisa, because you were talking about homelessness and now you're talking about family violence and the justice system spewing people back out into homelessness. And but I do think that it's about touching a chord with people that they might relate to. So I'm doing a lot of work at the moment around pregnant women who are homeless, which has been a hidden thing in our country, and we've mapped it to the number of kids being removed at birth into state care, and homelessness is a factor of that. And people are just so shocked, because I think, so it is about not saying you kind of game the system, but I think it is about finding what are those stories and the narratives that will appeal and strike a chord with people, and once they're a bit more informed, then you can tell. But I just, I work with peers who've been in the justice system and other things, but I find that if that's my go-to example, straight away some of those shutters come down because there's people's stigma, and I think that's a real tension for all of us in this sector, that we want to bust down that stigma, but sometimes depending on who you're trying to convince, you have to pick strategically the examples you share of how really any of us in this room could end up homeless, and at least kind of work your way in through that.
I think I just want to add quickly, I think it's really important to relate it to the audience you're talking to. So the example I always come back to for myself is sitting in a room having an argument about whether or not to continue funding video observed therapy for TB in London some years ago, and we were talking about £30,000, which was peanuts in the budget for London, and they didn't want to do it. And the thing that convinced other people around the table was the idea that they might get TB on the tube, which is incredibly reductive and ridiculous, but it meant something to them. They didn't care that it was really innovative, that it was less clinician time, that it was just, it meant, so that's...
And to just take this a step further, it's really showing everyone that that they're affected by it directly, be that tax dollars, be that their business being vandalized, be that like their kids finding syringes on the playground, right? Like all those pieces. And so part of why we go out and go to public meetings, go to consultation meetings, sit at all of our implementation and funder table meetings, is to get all of these questions to, in the end, create messages, be that through infographics, through exhibitions, if somebody's interested in participant voices directly, creating academic papers, like really speaking to the audience. And we have the fortune to have great support by our city's communication department, who put the Movement for Change, which was sort of a fundraiser around the whole of community systems response, on all the billboards in our city, with like just snap facts of like, here's what's being done, here's the money that's been raised, here are the hubs that are being stood up, down to infographics of like, okay, so 6 months ago, these were the numbers, now these are the numbers. Same infographics we can give to our city councillors because they're very curious about it. And so it's just around communication, and very clear communication, and recognizing there's people who want those numbers and who want to see, like, yes, last year in July 2023, it was 687 people. And now in July 2024, it's going to be 487 people. Like, just really, but then there's also those people who want to hear the stories, right? Who want to see the artwork created by folks supported in the highly supportive housing programs. And it's really just, that's why we are so keen on that mixed methods approach, because it's a whole of community systems response to health and homelessness, which involves all of London for us. And I think a response like that should include all of the members of the community, and really to cater to everyone. I hope that helps.
Yep. If I could just quickly add to everything that Nick said, that was brilliant. Being consistent with the messaging, though, to the community is so fundamentally important, because there are detractors, there are people that don't want to waste money on this issue, as they would say, and which is shocking. But something as simple as one study said we had 600 people, the other one said we had 1,000. They don't know what they're talking about, they're making it up. Like, it's amazing how that can get spun so quickly. So that's a big part of why we're trying to take the approach that we are, to coordinate our efforts so we can have a unified messaging around it.
Thanks. Thanks very much. I suppose from what I would say is, a lot of people, I would say, do need to hear more about it, because it's somebody else, whereas in fact it could be any one of us. So it's actually really personalising it. And one of the things I did in University College Dublin, where I work, was to develop a module for undergraduate students called Understanding Homelessness. And I used design thinking as techniques to develop that module. So it's built into 3 different components. The first component, the students come from all different colleges, schools. If they're interested, it's an elective module. Do you understand actually what's a home, what's important to them? Do you know that idea of, if you have 15 minutes to leave your home, what do you take with you? And all that idea of who's around you and everything else. So they do that for a few of the classes. Then, because of the concept of the module, there's the policy colleagues come in, and they talk about all the policy developments that we have and what we know that's developed. And then the final phase of the module is actually bringing in solutions. And they meet people. Focus Ireland in particular has an ambassadors programme, and they are people who are exiting homelessness and come in and they share their stories of actually what they're doing. This idea that there's somebody different, or there's somebody lacking, or what they're doing. We all have strengths and creativity, and if we have the opportunity and the space put around us to thrive, and that's what the students in the class learn. So at the end of it, they have to pitch what an idea could be, and in groups. And when you start a module and you say you're going to have to present in groups, everybody's heart sinks and they feel really sad about themselves. And then when they hear 2 people who have experienced homelessness come in and spend 45 minutes talking to them about what their life was like, and now what they're doing and where they're working and how their lives and everything else, it actually diminishes that fear in yourself. And the feedback from the students on the module that I see, the anonymous feedback, is, you know, what they say is, they reflect and they say, I thought being homeless was people living on the street. And these are students who are in university, okay? I had no idea what that meant. Thank you. And they thanked the people, and the ambassadors were there 2 weeks ago, and they said, thank you to your students, please say thank you to your students, because they were so engaged and interested in who they were, and they really facilitated us, they provided a safe space for us. And my colleague here, Maxine, she came, she spoke about actually the services she's providing and everything else. They have no idea where they hear that. So I agree, it's actually making it seem that it's not an other group of people or it's something different. I think more people do need to understand that it could be absolutely anybody else. And other studies that I've done, I've used photo voice, and again, the photographs that people who have experienced homelessness, young people, have taken, and we've exhibited their photographs. They haven't said who they are, they're afraid themselves, but we know they come and they see their photographs. And people say, oh my goodness, how can they do this? And I went, because they're just like you and me. In fact, they're better than me, because I can't take a good photograph. So I think there is that sense of understanding it could be absolutely anyone. There's so many students in college and many people, as you said, you work with, they actually are experiencing homelessness. There's food precarity all around us. There is housing precarity. There are people living in their cars and then going to lectures, and they stay in their cars for 2 or 3 days, and then they travel back because they can't afford accommodation. So that's reality.
Okay, thank you very much. I'm afraid that we are running out of time now. If there are more questions, I invite you to approach our incredible panelists today. And last thing, thank you very much for coming. And we have a little box gift for everyone. So if you don't have yours yet, please approach our colleague Neve. And thank you very much for coming.